Welcome to another Puscast Puscast. Review the infectious disease literature with commentary for the first 2 weeks of February 2009. This is a very special Valentine's Day edition in that we're only going to talk about sexually transmitted diseases. Just kidding. For those of you who are sick of this intro, you can skip ahead to the next chapter. This is on iTunes, and as always, if you like this, feed my ravenous ego with a glowing review. That's all I ask. Feed my ego. The usual business I have to take care of. This is brought to you by Pusware LLC, the publisher of the Persiflager's Annotated Compendium of Infectious Disease Facts, Dogma, and Opinion. Your uber hyperlinked electronic guide to infectious diseases at pusware.com. Because this is CME accredited, and after you're done, you can take the online quiz and get a half an hour free CME. Thank you, Legacy Health System. I have to mention my conflicts of interests. I have none. I haven't talked to a drug rep in probably 25 years now or so. That's not saying I don't want to sell my soul. I would be glad to for the right price. As always, as a warning, this is not called Persiflagers for nothing. It will contain snide comments, sarcastic asides, and don't complain that I didn't warn you in advance. Operating under the ongoing assumption that the world does need more Mark Crislip, I have another podcast, my Quackcast, where I review supplements, complementary, and alternative medicine. I blog twice a month for the Science-Based Medicine blog, and my own blog on infectious diseases at Rulor, Dolor, Kalor, 2 more. Now, on to the literature. Remember, all the references are available online. Every country has their anti-vaccine wonkery. In the United States, first it was vaccines containing too much mercury. Now it's too many vaccines too soon. However, in England, they had a guy named Wakefield who published an article in The Lancet that suggested that the MMR was associated with autism and that he had these children who developed inflammatory measles in their colon, of all places, after the MMR, and normal children subsequently and right after getting the vaccine developed autism. Turned out he was either a liar or an incredibly incompetent researcher. It turns out that many of the children had pre-existing developmental issues before the vaccine, but he reported them in the Lancet article as developmentally normal. He also did not mention in his article that he was funded by plaintiffs' lawyers who were having suits against vaccine makers. So it's the wonderful combination of incompetent research plus incredible conflicts of interest have invalidated Dr. Wakefield's hypothesis that the MMR is a cause of autism, which it's not. If you're interested in more on this topic, might I suggest either Respectful Insolence or Neurologica, 2 excellent blogs. One of my many jobs is infection control, so I'm interested in hand hygiene. This was a curious study where they took a bunch of healthcare workers who were vaccinated and smeared their hands with 10 to the 7th infectious doses of influenza virus, and then looked to see whether hand washing or one of 3 different alcohol-based hand scrubs could eradicate influenza from the hands. And not unsurprisingly, both hand washing and alcohol-containing products of various types were very effective in removing influenza from the hands of healthcare workers. There was a slightest of edges towards hand washing with soap and water, which had about 100 particles less than those that had the alcohol-based hand hygiene products. Lady Macbeth in this day and age would probably do alcohol foam and then wash her hands. A recent study looked at MRSA carriage rates in uniforms and long-term care facilities and found it's not infrequent to find MRSA in and on uniforms, especially in the schmutz that collects in your pockets. So now we have 3 studies that have found ties to have pathogens, one that's looked at beepers that I'm aware of, several that have looked at stethoscopes. Now, I want to emphasize it's never been shown that these have been associated with transmission, but nonetheless, I think we need to give up our ties, our beepers, our stethoscopes, and go to work naked. It would be just like the ancient Greek Olympics. It turns out that the bats in the American Northeast are dying off at a huge rate, with declines exceeding 75%. This has been due maybe to a fungus, where these bats have what's called white nose syndrome, where they develop this mold that covers their face and wings. The bats appear to be infected, or colonized at least, with a Geomyces species that is hitherto undescribed as a pathogen, and that this organism is a psychrophilic organism. I didn't know there was such a word as psychrophilic, but it means cold-loving. So the bat populations in the American Northeast are in marked decline because of this infection. Now, why would you care? Besides the fact that Bruce Wayne is very upset. Well, bats eat bugs, and bugs carry disease. So one would wonder if we're going to see an uptick in human infection from mosquito and other bug-borne illnesses because the bats aren't eating them. We'll see if we get a bumper crop, say, of West Nile this year in the U.S. Northeast. Since, according to the interwebs, one bat can eat 600 mosquitoes an hour. You can put a man on the moon, but you can't cure the common cold. Well, we all know that the moon landing was faked, so maybe that's not a good example. But it's going to be harder to cure the common cold than you expect. This study looked at rhinovirus genome and found incredible diversity in the different rhinovirus serotypes, with 40% nucleotide variability among different strains, and the organism swaps its genes with each other with astounding ease and frequency. It would appear that the rhinovirus is well equipped to never prevented with a vaccine nor cured with a medication, because the genetic variability would prevent either from working for long. It helps explain why the average adult gets 2 to 4 rhinoviral infections a year, because immunity does not exist because of the great variability in this organism's genome. So it would appear that the only effective therapy out there is going to be airborne. Not. Now, in the United States, we don't see polio anymore because of the vaccine, and everybody gets the vaccine. Well, everyone should get the vaccine. Now, most people in the United States now get the inactivated polio vaccine. Because of the low incidence of polio, we use a slightly less effective vaccine because the live vaccine occasionally can cause polio in real people. Well, the Amish don't routinely get vaccines, although they make nice fireplaces, according to my newspaper. And what happened in Minnesota was that the vaccine-derived strain got into the community. It circulated for about 2 months in people who were not getting vaccinated. And then some poor baby with severe combined immunodeficiency got the vaccine strain and got polio. This demonstrates not only the importance of herd immunity, where if everybody is vaccinated, then nobody gets disease. If everyone had been vaccinated, that baby probably would have been protected from being exposed to polio, but also keeping an eye out for polio in the United States. Most of the cases that I've thought were polio were actually other enteroviruses, but there's always the case that some strain of polio or vaccine-derived polio will sneak back into the United States and cause disease, especially thanks to people like Andrew Wakefield and Jenny McCarthy. Vaccines are not being received at the rates that they used to. We eradicated smallpox in the world using a vaccine derived from cowpox. Curiously, that vaccine-derived strain has now become an endemic zoonosis in South America, specifically Brazil. There's a case report in Clinical Infectious Diseases of a Brazilian cow worker, or would that be a co-worker? No, that'd be a cow worker. Anyway, a guy who works with cows who developed the vaccine-derived pox disease on his hands from handling cows. How this virus got into the cow population of Brazil and how it is spreading in Brazil is not known. But there are other cowpox circulating around in the world. One hopes it never mutates in a way that allows it to take over the virulence of the now defunct smallpox. A study out of Norway looking at influenza A resistance, they found in last year's season that 67% of their strains were resistant to oseltamivir. These strains were collected in 272 patients, 2 of which had been vaccinated. Boy, I wonder what the other 270 thought. The other interesting thing about the oseltamivir resistance is that nobody who developed this had prior use of oseltamivir. And the other interesting thing is that these organisms were not less fit than wild-type strain. Often resistant organisms are less able to replicate, but this organism was perfectly hardy and perfectly resistant to oseltamivir. So it'd be depressing as hell if we ever get a pandemic strain that we don't choose the vaccine right the year before and it's resistant to oseltamivir. We could have lots of morbidity and mortality. Speaking of pandemic flu, this was a survey done in Australia where they asked a bunch of questions of people in hospitals as to how they're going to respond if there's an avian influenza pandemic. In this study out of Australia, 83% of people said they would come to work despite the potential risk. This is better than the United States, where surveys have suggested that only 50% of healthcare workers will show up at work. Interestingly, in their study, non-healthcare people, i.e. ancillary staff, were even less likely to want to show up to work than nurses and physicians. People always think more highly of themselves than the evidence would warrant, so I would take that 80% number and half it. United States, I'd take that 50% number and half it. So if you are involved in avian influenza preparedness, just go around the table and assume that half the people there won't be there come the pandemic. It's especially true that people are less likely to come to work in these surveys if there's a ill family member. So taking into account protecting healthcare workers' family members may help make sure that you will have people in the hospital to help take care of the dead and the dying. As we have talked about before, the HLA-B5701 is associated with abacavir hypersensitivity. You'll be happy to know that in 534 Korean patients who were tested for HLA-B5701, no Korean had that HLA type. So unless they have parents from the West, you can pretty much not worry about Koreans having an abacavir hypersensitivity reaction. And as long as we're on the topic of HIV, this study looked at the comparison between interferon gamma tests in HIV patients and a skin test looking for latent TB, and found that the quantiferon type tests were not good and did not correlate well with the skin test. And not unsurprisingly, if the CD4 counts were under 200, they were less likely to have a useful test. Like any other test that requires an immunologic response, them what have a bad immune system are not likely to have a reliable assay. This study next is important for the United States Navy. They looked at a series of men who had suppressed viral load and looked for the presence of HIV in the semen, and they found that semen could often have high amounts of HIV despite serum copies of less than 50. Patients had as much as 5,000 copies per milliliter of semen for HIV. These studies were done in small numbers of patients, but it would appear that somewhere between 25 and 30% of patients with suppression of HIV in their serum will still have detectable HIV in their semen and are potentially infectious to other people through sexual activity. Good news, I suppose, for the Trojan company. Now, the HIV, to get into the human cell, requires 2 receptors. It either first has to bind to the CD4 receptor, and then it has to interact with either the CCR5 or the CXC chemokine receptor to be taken into the cell. Now, they had an HIV patient who also had AML. They gave him a transplant from a patient who was homozygous for a deletion of the CCR5 gene, i.e. they had no chemokine receptor. And they gave this HIV-positive patient a bone marrow transplant with those cells. And after he got the transplant, he had no rebound in his HIV. So they sort of controlled his HIV by transplanting him with cells that were not able to be infected with HIV. This is kind of cool. I don't know how practical it's going to be, but it's a nice in vitro demonstration of the importance of these receptors in the perpetuation of HIV. Sometimes you just like the title of an article. This one's entitled Ataxia Following Altercation, ... with a cat. This gentleman, 8 weeks prior to admission, got scratched by a cat on his hand, and he came in with progressive neurologic symptoms and Bickerstaff's brainstem encephalitis secondary to cat scratch disease. I didn't know Dr. Bickerstaff had a brainstem encephalitis named after him. The patient got better, and he was serologically and pathologically diagnosed with cat scratch disease. I'm sure you already know this, but Bickerstaff's brainstem encephalitis consists of acute ophthalmoplegia, ataxia, drowsiness, and hemisensory loss, which this gentleman had. Cat scratch does have a propensity of affecting the central nervous system in normal people. 8 weeks is a pretty impressive lag time from the injury to the disease, and a careful history of cat exposure is probably a benefit in any neurologic symptoms. The best way to prevent this, of course, is to autoclave your cats, which tends to eradicate the cat scratch. And Dr. Jones, I expect you to mention Bickerstaff at least once in the upcoming month during Noon Report. I usually just assume that Leptospira are susceptible to the usual antibiotics we use, i.e. beta-lactams and macrolides. But when you assume, you make an ass of you and me. Oh, that's so clever. This study looked at leptospiral antibiotic susceptibilities from around the world and found that those from Egypt were slightly more resistant to the tetracycline groups than those from Thailand or Hawaii. The other interesting thing is the MICs to doxycycline and tetracycline were remarkably high at 2 and 4 micrograms per mil, respectively. And it certainly looks like the best bet for the treatment of leptospirosis remain the beta-lactam antibiotics, as well as clarithromycin, all of which have vanishingly small MICs. 2 cases of cervical lymphadenopathy that turned out to be due to syphilis was the topic of this case report. Now, primary syphilis usually causes lymphadenopathy, and the ulcers are usually asymptomatic. Neither of these patients had risk factors. Ha 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 ha. Everybody lies about their sexual exposure. But I never thought of the consideration that oral sex would lead to oral ulcers that one may not notice and subsequent cervical lymphadenitis. So that needs to be on your differential diagnosis of cervical lymphadenopathy. And in both these cases, cervical lymphadenopathy was the only symptom the patient has. I frequently see patients with prolonged cervical lymphadenopathy, so that now needs to be in all of our differential diagnoses. The number one cause of bacterial meningitis in parts of Southeast Asia is now Streptococcus suis. There are multiple strains of this organism found throughout the world. It tends to cause diseases in humans and meningitis in humans. There have been a smattering of cases of this disease in the North American continent. And there's a letter to the editor showing yet another pig worker coming down with Streptococcus suis meningitis. What's unusual about this one is that in most cases are due to serotype 2. She had serotype 14. So when you're out there playing with your pigs, look out for the Streptococcus suis. The plague of MRSA that we've seen in the United States for the last 7-8 years has been the USA, oh, pardon my jingoism there, the USA 300 strain. And I had presumed that this was the same strain all over the world. I presumed wrong yet again. In England, their MRSA that's causing community-associated infections is not the USA 300 strain. While we have organisms that make a lot of Panton Valentine leukocidin, their strains do not. So it appears that there are different MRSA outbreaks occurring simultaneously in the world, one in the United States, one in England. I think it'd be important under these circumstances to keep all people from England out of the country so that they don't bring this strain into the United States. And I'm sure Homeland Security can do that quite easily. Bad breath is probably an infectious disease, wouldn't you know it? Now, we talked a while back about how patients with Helicobacter who get treated have their halitosis disappear. This study looked at H. pylori DNA in patients with halitosis and found that patients with bad breath were more likely to have H. pylori in their mouth. They're also more likely to have anaerobes in their mouth, higher levels of methyl mercaptan, and more likely to have periodontitis, including increased risk of Provotella. So Helicobacter may be part of bad breath, which is far more important than peptic ulcers or gastric cancer. I'd much rather have cancer than bad breath, wouldn't you? But this study, combined with the prior treatment study we talked about, and it is the royal we here. I am the King of England. Didn't you know that? But these studies suggest that patients with bad breath may benefit from both testing and treatment of Helicobacter pylori. I'm back. Did you miss me? It's actually been 24 hours since the last entry. I'm on winter break with my youngest down at the beach. We've played golf. We've walked on the beach. We've gone out to the video game place. Endless excitement. Now back to infectious diseases. ID, of course, is nothing but applied Darwin evolution. I'm a Darwinist. Oh, my God. And the issue here is the impact of the pneumococcal vaccine has had. The pneumococcal vaccine, the new one, covers 7 strains of pneumococcus, the most common strains found. The use of this vaccine, which is very effective, has led to the decrease in invasive disease due to the strains covered by the vaccine. These strains were also the most antibiotic resistant strains, so subsequently we've seen a decrease in the number of strains of pneumococcus resistance to antibiotics. But what this has done is opened up ecological niches. And as a result, new strains of pneumococcus are coming into human beings. They did a strain type in Massachusetts and found that whilst 6A was never seen before 2001, serotype 6A is now a common cause of nasopharyngeal colonization due to pneumococcus. Now, it's currently more susceptible to antibiotics than the strains covered by the vaccine, but you can predict that over time, these strains will become more resistant. As I've said before, the Borg only have it half right. Resistance is inevitable. What we really need is an 82-valent conjugate pneumococcal vaccine. That will get rid of the bug for a while. So the pneumococcus causes pneumonia in adults, and pneumonia causes changes in chest x-ray. And the chest x-ray is the topic of this podcast section. Man, am I the master of the Segway or not? Not the two-wheeled personal transportation device that Par Blart rides, but the masterful transition between topics that I'm so excellent at. Now, this just looked, and this is just one of those curiosity about what happens with chest x-rays with severe community-acquired pneumonia. And it turns out that progression of chest infiltrates is a bad prognostic sign, and surprisingly a worse prognostic sign than bacteremia. The study, which was published in Chest, looked at 457 patients in an ICU, and those that had a rapid progression of their infiltrates had a much higher death rate, and it was worse than if you had bacteremia, which in this study was not an adverse prognostic factor. The next 2 papers are from the Society for Critical Care Medicine and reported in Medscape, so they're not papers yet. The first one concerns the use of statins in sepsis, and this is another study that shows that statins are effective in decreasing mortality. This study looked at 25,000 patients who were hospitalized with sepsis over a 5-year period, and found that patients who came in on sepsis had a 30% lesser mortality than patients who were not on statins. So if you're planning on becoming septic in the future, you might want to be on these agents anticipatorily. I always recommend talking with a psychic first. I used to always talk with Miss Cleo, though she's unfortunately been put out of business. Call me for your free reading now. I wonder why she didn't see that coming. Anyway, the data is mounting on the beneficial immunomodulatory effects of statins in the septic state. Ooh, does that sound like a professional summary or not? The other study out of the critical care meetings is concerning delirium and sepsis. They looked at 14,000 patients who had a cabbage in 2 centers in Canada and found that they had 981 patients with delirium and 246 patients with sepsis. It turns out that in 75% of the septic patients, delirium was the first sign and increased, of course, their mortality rate. Sepsis being a bad thing for everybody but the infectious disease doctor. So if you have a patient in the ICU who's had a cab and is being delirious, that may be a marker of sepsis. And perhaps the patient is deficient in strong, big gun, powerful antibiotics. Broad spectrum ones, too. I usually don't include animal trials in this podcast because I try to make it clinically relevant, but this study I think is important. There's been a small but growing literature to suggest that the combination of a beta-lactam and a macrolide is the preferred therapy for community-acquired pneumonia because it decreases mortality. Why does this happen? I had long thought that it was the macrolides interfering with the protein synthesis and a decrease in the virulence factor that was associated with a decrease in mortality. Other studies that have been talked about in this podcast have suggested that, in fact, what's probably happening is an immunomodulatory effect on the host, since severe pneumonia treated with macrolides and the patient's organism is resistant to macrolides has a better outcome. This study looked at mice who were given influenza pneumonia and then secondarily infected with strep pneumo and found that getting a macrolide was associated with decreased mortality, and that on histopathologic findings, they had decreased inflammation and smaller amounts of inflammatory cells. The animals that were treated with macrolides also had less cytokines in their lungs, a marker of decreased inflammation. Now, whether or not it was due to the fact that the macrolide was decreasing protein synthesis in the strep pneumo, so there was less to have an inflammatory response to, or whether or not it was having a direct anti-inflammatory response due to immunomodulation, is not certain. I think it's safe to say, though, that macrolides plus a beta-lactam should be your treatment of choice in almost all forms of sepsis, whether or not you think the patient has pneumonia or not. This is a developing area in medicine, but the data is certainly strongly suggestive, and I'm sure there'll be more trials down the line. It would appear that everybody who's septic needs to be on both statins before they come in and a macrolide once they come in. My youngest goes to Portland French School, a French immersion school, and part of their program they have to learn a third language, and I inflicted Chinese on him because I figure that he's going to have to be able to talk to our economic masters in the future. The problem with going to China, however, is they have a lot of resistant tuberculosis. Their rates are about twice the international average. Worldwide, MDR-TB is about 4.8%. In China, it's 9.3% in new cases, which is pretty impressive, almost 10%. And a quarter of previously treated cases have MDR-TB, suggesting they're not giving optimal therapy up front. Other diseases that are increasing in China include syphilis and HIV, so if you go to China, be very careful. The importance, of course, is not that you're going to go to China and get MDR-TB, but to keep that in mind when assessing immigrants to the United States from China, which will probably be a decreasing phenomenon over time. One of the occasional interesting themes of this podcast has been vitamin D deficiencies and polymorphisms as a risk factor for infectious diseases. This study looked at vitamin D as a supplement treatment for tuberculosis and found that it made no difference in outcomes. They treated patients with 100,000 international units of vitamin D or placebo plus standard therapy for tuberculosis out of Denmark and found mortality and cure rates were the same in both groups. This does not surprise me in that I would expect patients in the West to respond well to therapy and have no extra benefit from vitamin D. The benefit probably comes in patients who have deficiency states before they get infections and making sure that everybody is not deficient in vitamin D. Extra vitamins never help. There's yet another study out recently in the JAMA to show the lack of benefits of vitamin supplementation in normal people. The key is to have deficiency states eradicated. In the West, we don't tend to suffer from vitamin deficiencies, except perhaps in the foggy, cloudy Northwest. Vitamin D deficiency is not that uncommon. Mycobacterium bovis mimics tuberculosis, and people usually get it from cows. We've talked about in prior podcasts that there's been an increase in M. bovis at the California-Mexican border, primarily in Mexican immigrants who are exposed to this organism through cows. There's now a case out of France where a Mycobacterium bovis went from cows to humans. In the process, it had a mutation, and then it went from human to human into immunocompetent patients. So Mycobacterium bovis can be spread within families and can be difficult to differentiate from MTB unless you're looking for it. People who are around cows are at risk for Mycobacterium bovis. I guess people who pretend to be around cows get Mycobacterium bogus. There, that's the stupidest pun I could come up with today. In a prior podcast, I talked about a study that looked at Staph aureus intravenous catheter culture tips, and if they're positive in the absence of blood cultures, patients still have a high probability of developing a subsequent Staph aureus infection, and patients with Staph aureus on a intravenous catheter culture tip should be treated. Is this true of other organisms? This study looked at Candida on catheter tips and found that patients did not have an increased risk of candidemia, and so that antifungal therapy here did not seem to be a benefit, although it was small numbers of patients. And the more places that you grow Candida albicans out of a patient, the more likely they are to be fungemic. This is still an area that makes me nervous to ignore. But unlike Staph aureus, there's not the data to support the automatic treatment of a intravenous catheter tip that's cultured out Candida albicans. And just as an aside, well, it's not an aside, but just a short report, CDC reports that cocci is increasing in California. Now, whether or not this is due to climactic change or other things to result in increased amounts of cocci, the rates have gone from 2.4 to 8 per 100,000. There must be more cocci in the air, so people are inhaling it for whatever reason. People do like to go to California for their vacations, and practicing in the Pacific Northwest, people often go back and forth from California along the truck routes. I've seen 2 patients who've gotten their lungs removed because they thought they had lung cancer, and what they had was chronic cocci pneumonia. They were both truck drivers who do the I-5 corridor, and chronic cocci can look for all the world like lung cancer. So before you whack someone's lung out, might I suggest a careful history and physical? Nah. Well, ladies and germs, that brings us to the end of yet another Puscast. The Persiflager's Puscast, review of the infectious disease literature with stupid puns. All the references, including many not mentioned in the podcast, are available on the website. This is CME accredited. Now that you've listened to me, take the online quiz and get a half an hour of free CME, thanks to Legacy Health Systems. This has been brought to you by Pusware LLC, the publisher of the Persiflager's Annotated Compendium of Infectious Disease Facts, Dogma, and Opinion, your uber hyperlinked electronic guide to infectious diseases at Pusware.com. Don't forget, the world needs more Mark Crislip, so listen to my Quackcast, read my blog entries at sciencebased-medicine.org and Rubor, Dolor, Kalor, 2 more, and write me a glowing review on iTunes. My ravenous ego needs constant feeding. Bandwidth ain't free, so feel free to purchase the compendium or otherwise support this podcast. This is copyright 2009 with the Creative Commons license. See www.creativecommons.org. The music is by my son when he was 12, improvising on the guitar. And as always, thank you for this most interesting consultation, allowing me to participate in the care of this most difficult and challenging case. I will continue to follow along with you. Thank you. In dictation, goodbye.